everybody in our session of the EUDF, our EUDF Symposium at the annual EASD meeting called Digital Health, Hope for Diabetes in an Uncertain and Changing World. Welcome to you all. Here you can find today's agenda. I will first briefly introduce the EUDF. Then we will go through several speakers on increased digital diabetes services. Excuse me, there was some feedback here on my side. I apologize, but things will be smoothly now. So first of all, we will have a discussion, as said, on digital services, and then on country-specific examples. And then I will hand over the chair to my colleague, Professor David Matthews, who will lead a discussion on integration of digital services in chronic disease management, specifically focusing on what has happened during the COVID epidemic, but also opening up perspectives for after the COVID epidemic. And then we will come to a roundup, to a conclusion. So I will first start with an introduction of the EUDF, because we are still quite a young organization, started by the founding members that I will introduce later on. So why was EUDF founded? Well, because there is still an issue with diabetes, not only in Europe, but worldwide. But specifically with the EUDF, the European Diabetes Forum, we want to create a platform bringing together all stakeholders in diabetes to really harmonize our effort, harmonize our voices, and come to policy action. Why? Because if we look at the outcomes of diabetes, they're still poor overall, and that despite amazing scientific progress, like you have witnessed at this week's EASD conference. Also, despite the multitude of new treatments that, again, you have seen presented at this week's conference. The prevalence of diabetes is around 10% and especially growing in specific populations. Let's think about type 2 diabetes, where in certain ethnicities, we are now really faced with diabetes epidemics. And also, let's think about type 1 diabetes becoming a more and more aggressive disease and affecting children at younger and younger age. A big challenge, and again, the COVID epidemic was a very good example of that challenge, namely the fact that we need good data. We need good data to guide us in our decisions. We need good data to help us plan interventions. And accessing these data, especially in Europe, is not so simple. Also, there are unclear and unavailable economic data on diabetes and on its complications, because indeed diabetes is a very costly disease, not particularly so because of the diabetes itself, because of the treatments themselves, but because of these devastating complications. Think of eye disease, think of vascular disease, think of renal disease. And then we have this lack on political engagement. And looking at mainland Europe, looking at the European Union, we do have a problem that healthcare is organized at the national levels, but also in the wider Europe and also in the UK, when we look at the situation after Brexit, there is this lack of political engagement, where we believe that with the EUDF, we can make a difference. As said before, we want to bring together all stakeholders to really align priorities, urgencies, and speak with harmonized voices to achieve policy results. Now, what is our vision? What is our mission? And I invite you to go to our website, eudf.org, to read more. Our vision is to enable healthcare systems to cope with this diabetes epidemic while achieving the best possible outcomes for people living with diabetes. And our mission is really to translate the research into policy actions towards better diabetes care at a European level. But as said, because healthcare is organized at the national level, we need this translation to the national levels. And I'll show you how we want to do this. I alluded to the fact that EASD was at the cradle of the EUDF. We were one of the founding members, together with the European Foundation for the Study of Diabetes, the EFSD, together with FEND and JGRF. But I'm extremely happy to say that very rapidly, since our inception in the beginning of this year, we have now already been joined by the International Diabetes Federation Europe, IDF Europe, and by our supporting collaborators from FPA, from the pharmaceutical companies. You see them listed here. Pending membership is also there from Primary Care Diabetes Europe and La Société Francophone du Diabète. So we are growing to have really the relevant stakeholders to speak with harmonized voices in making this difference for diabetes in Europe. And so we want to be an inclusive community. We are open. So if you are an association, if you are an organization, do contact us. And you find our contact data at eudf.org. You can just send us an email also at info@eudf. To postulate membership or to give us ideas of how to progress. Now, this is how we want to see our structure. I told you that we have a forum where we want to be inclusive. We want to be open to all stakeholders. We have a board, a kind of board of directors. We have an executive director who is Bart Torbijns. And then, as said, we want to translate everything we do in the European Diabetes Forum to national fora. And I can tell you that we already have 3 countries where these national fora have been made: Germany, Romania, Belgium, where the same idea of putting all the stakeholders together in order to speak with harmonized voices and make policy changes to make lives of people with diabetes better, that has happened at a national level. But instead of being just in the air and making a lot of blah blah, we want to be very practical, and we want to put meat to the bone and work on 3 specific topics. And here we show them as pillars in this European Diabetes Forum. Indeed, we want to put emphasis on data and data registries. So there will be what we call a strategic forum led by an expert and with a small expert group who will look at what the needs are on these data and registries in Europe and elaborate policy recommendations on that. There's also a strategic forum on integrated care, access to care, and then the central by coincidence, it's here central, but so the central strategic forum that is also the topic of today's symposium, namely the use of novel technologies and the place of digitalization in the care for people with diabetes. Now, as said, we became a legal entity in February of this year. And since then, we have achieved quite a lot already. We have made the structure, we have made a strategic plan. Our friends from FPA have joined us in making a webinar specifically on integrated care during the COVID epidemic. We have had an executive forum already with the leadership also of the FPA companies. We have made not only our big overall strategic plan, but also a very specific tactical plan. And I already introduced Bart Torbijns, who was recruited in August as our first executive director. Then IDF Europe became a member. And again, today is one of our highlights too, where we have our first EUDF Symposium at the occasion of the EASD annual meeting. And as said before, we very quickly want to move to start working on our strategic fora, the 3 pillars: integrated care, access to care, and digitalization. So, very brief introduction, and again, keep an eye on our website. We are updating it, we are making it a lot bigger than it is now. I would also invite you to create your own avatar at this year's EASD and visit our booth at the EASD Plaza at this year's annual meeting, where you can find a lot of materials, where you can see a little movie, where you can have folders, not only on the big European Diabetes Forum, but also on the local fora, Belgium, Romania, and Germany. I wanted to be brief. I promised our executive director I would be brief so that we have plenty of time for our speakers on the topic of today, namely digital diabetes services, digital care in periods of COVID and beyond. And so let us move now to the next part in the agenda. And here we will go on now with different speakers. And the first speaker I invite to join us is Tanya Valentin from Medtech Europe. Tanya is the Director External Affairs of Medtech Europe. Tanya will discuss on the vision for digitally enabled diabetes care in Europe. And so, Tanya, as I announced earlier on, I will advance your slides, but you can see them in the preview as explained.
Thanks a lot, Chantal. Good to see you all. Good afternoon, ladies and gentlemen, dear chair and dear fellow panelists. My name is Tanya Valentin, representing Medtech Europe. And first of all, congratulations, Chantal, and all around you for having this important panel debate of EUDF at the EASD. So we are very thankful also for the opportunity to participate, and we are also in discussion how we can contribute best in your consortium. So next slide, thank you. I have 6 slides for you, and also will stick to the 7 minutes. A brief introduction. Medtech Europe is the voice of medical technology industries in Europe. We represent manufacturers of medical devices, diagnostics, and digital health solutions. Within Medtech Europe, we have a group, a diabetes sector group, which brings together 9 leading diabetes technology companies, which I represent today. And the group, as you see, has 2 main objectives which we want to work on and move the needle. It's about applying value-based healthcare in the area of diabetes. And secondly, is supporting the digital transformation of diabetes prevention, diagnosis, and care, both with the ultimate aim, of course, to serve people living with diabetes in the best possible way. So next slide, please. I would like to present to you the findings of a vision paper which we have released last week, actually. And before doing that, I would like to explain a little bit the elements of the context where we are operating within today. The first ones are very well known. We know the high rates of prevalence, Chantal mentioned it. We know the healthcare system constraints in terms of funding. I would like to put attention to a third one which we see, which is a big seismic shift that digitization has brought already to our society in many other areas. And let me give you 2 examples. As of today, the biggest taxi service in the world does not own any taxi. And secondly, the biggest hotelier in the world today does not own any owned hotel. Think about Uber and Airbnb. It will sound a bit provocative maybe in our audience today, but we have to think ourselves together. Do we expect similar shifts for healthcare delivery in the future? And if so, what does it mean in the area of diabetes care? And how can we ensure that people with diabetes are kept in the center of such seismic digital transformation in healthcare? And the 4th driver, which you see, is of course the COVID pandemic. We have to wonder what lessons have emerged what are we still learning, and how does it affect the course of digital uptake? That is why we engaged in this vision exercise. Next slide, please. So we held in-depth interviews with a range of leading experts in the field of diabetes. That was in the month of April, May this year. And these experts reflected on the aforementioned trends for the future of diabetes management and care. Amongst them was a strong patient voice, anchoring us on the focus to people with diabetes. So IDF Europe chair, Dr. Niti Pal was there. Bastian Hau contributed, who is also part of the panel today. We spoke to practitioners with a strong engagement in digital exploring solutions, for example, in Germany and the US. We included also the views of the leaders of our technology industries to this vision paper, and we come to rich insights, we think, on this. This whole project was planned before COVID came in and was undertaken in the middle of the peak of the pandemic. So the circumstances that we were all catapulted into at that time leaped us forward in the way I think we look at digitalization. And that was done in a speed which we couldn't have imagined 6 months ago. So we are in a totally different place today. And the discussion has changed tremendously of what we have discussed in January this year. Next, please. So to start off, in the beginning of the interviews, we asked the experts to rank a series of statements on the future of digital care from 1 to 10. And there were several key areas where there was strong alignment, and I only want to name 2 here. It is expected from the expert interviewees that a big positive transformation in diabetes care is around the corner. So everybody is expecting that. That is expressed through the 8 on the left-hand side. And also that is expected to have a fully integrated care in 2030 to be the norm at that time. And we know all how much work still has to be done, but the expectation is that we have succeeded doing that in the next decade. Next slide, please. And that is the key one, which has finding and challenges of the vision paper. So all and foremost, there was broad agreement that digital tools will empower people with diabetes and improve the quality of life. There was no doubt from any of the stakeholders' perspectives. Secondly, the fully integrated care to be the norm in 2030 was also common agreement. And here, smart technologies and AI play a core pillar of this transformation and integration. And another noteworthy comment which was shared was also that the routine clinical appointments, as we know them of today, were seen to come to an end. Some said it's the death of the clinical appointment. Some others nuance it and say it will look completely different than we know today. But certainly it's changing tremendously. Third finding was that digital technologies will allow to apply the value-based healthcare and will allow to do the patient journey centricity, what we all talk about, and not the healthcare centricity, which we are stuck with currently in many cases. And it will also come with a convergence and an expectation on the different sectors like Medtech, pharmaceuticals, ICT to converge together. And you can name it even broader with food industries, gaming industries, that this all will converge on a digital level, let's say. And the fourth one is about COVID. It has shown that digital solutions can work. And the call for digital uptake has been accelerated, all based on the needs for people living with diabetes. So these might be promising developments, and they all come also with short and longer term challenges, which were identified. On the shorter term, I would like to outline that there's seen a high risk of reversion to pre-COVID times. There's a big question mark how to sustain the digital health tools and solutions that were used and implemented under COVID-19 emergency laws in member states, and there's a big risk of backsliding. On the longer term, it was seen that also there is an unequal patient access to digital services. and solutions, for example, via gaps like digital literacy, and the question how to not let that gap widen, but have it closed. And the second set of challenges is about the readiness issues. There's observations still on concerns about data privacy, gaps in policy mechanisms, and here, in particular, providing the right incentive structures to unlock the digital solutions, which then can lead to better outcomes and care. Having said that, there were three key findings for the last slide, which the audiences or the interviews said that needs to be done as the next step of homework. We need to validate the experience of telemedicines and other digital solutions during the COVID to lock in the advances which we made. So we have to measure the impact of the changes. They must be documented and studied further. Secondly, ensure that the people with diabetes have a voice which is more integrated of what we still see today. We are not at the end point of doing a good job here to listen on the system side and on all stakeholders' side on the powerful public voice. And thirdly, clearly, the case needs to be very clearly articulated to policymakers. So instruments like value-based healthcare and appropriate incentive models can be instrumental to unlock better outcomes and in order to unlock also the potential of digitalization. That is for people living with diabetes as well as for care teams and professionals supporting them and also for health and social systems overall. That is the key findings. I will close with a sneak preview for a complementary project which we do to this vision paper. We engaging with the Economist Intelligence Study to complement and develop a digital readiness index. So we try to identify what does it mean for a system to be ready. Is it only infrastructure? Is it incentives and so on? And that should be released around World Diabetes Day. So I invite you to stay tuned also on our website. And I thank you all for the attention. And I hand over to the next speaker. Thank you.
Excellent, Tanya. And you heard I was not on mute. And I said, when you mentioned the reversal to pre-COVID. And I can tell you that is exactly what we were facing in the end of August. So in our country, we were able to move to online consultations, et cetera, and so our payers were trying to revert everything. And now I'm going to say something strange, but fortunately the second wave came, and now they prolong and they realize that we may be living in a new world. So I heard some extremely interesting things. I think Professor Matthews will also challenge our panelists. I heard death of the clinical appointment. We will see. Thank you very much, Tanya. And it is now, Aya, here is your email data. I leave it up for a couple of seconds so people can look at it. Okay. It is now with great pleasure that I introduce my good friend, Dr. Maurizio Guidi, who is the FPA Diabetes Group co-chair, who is working with Lily at Diabetes Corporate Affairs. And I can say, Maurizio, that together with your colleagues in different FPA companies, you were instrumental in really ripening this idea that we need to join forces all together, people living with diabetes, medical professions, as broad as they can be, to really push the needle on diabetes care. So please, Maurizio, I give the word now to you. And I'm extremely happy to say that we are joined now by over 350 people in this room already. So big interest, I can tell you, on this topic. So Maurizio, towards the future, diabetes care and digital services from your angle.
Thank you very much, Professor Mathieu and Professor Matthew, for the kind invitation to this very promising dialogue. And first of all, I would like also to reassure that I'm not Professor Mathieu has highlighted in the slides. My name is Maurizio Guidi. As said, I am the co-chair of the EFPIA Diabetes Platform. Let me also disclose in the following slide, EFPIA Diabetes Platform is diabetes-specific working group within EFPIA, the European Pharmaceutical Industry Association, that we group together to make, let's say, contribution towards the objective that you see listed on the right. That means to recognize the value of innovation, to improve, to make a contribution to improve healthcare outcomes, as well as also to make contribution for the sustainability of the system. That's our disclosure. Let's move to what has been my task to speak about the future and on diabetes care and digital services. Let me start with a consideration. You have been hearing from Chantal Mathieu and also Tanya Valentin about the epidemiology. At the present time, 60 million of European citizens living with diabetes. But more dramatically, every 8 seconds, that means 15 people during my short start, die for complication of diabetes. So despite this huge unmet need, diabetes is not a priority. And so the first fundamental question that I would like to ask to all of you that are together representing different stakeholders, are we doing the best we can for these 60 million of people living in Europe with diabetes? Are we doing the best we can for preventing that every 8 seconds someone dies for diabetes? Unfortunately, I believe that we are not. And I think that in EFPIA, we think that collaboration and partnership are the fundamental step for really building a better future for people with diabetes. So we are envisioning at EFPIA that collaboration and partnership can be a common practice, a standard of practice among stakeholders in the future. And we see in EUDF with a unique opportunity to bring together all the stakeholders in full respect of roles and responsibility, but to advance diabetes in political agenda with the final aim to improve outcomes, at the same time also to make a contribution for a sustainable healthcare. So if we can summarize, we believe and we hope, we wish, but we act also for having a more collaborative, more partnership approach in the future. The second consideration, please, if you can keep going with the next slide, we need to consider that the world is changing so an unprecedented pace. And if you can keep going, airline sector took, if you can click, took 64 years to reach the first 50 million users. You see from the progression that Facebook took only 4 years, but if you already click, if you click again, you see that Pokemon Go took 19 days. So the world is changing dramatically, and you have already heard that during COVID, some experts already highlighted that in few months, we saw the change that usually are happening in 5 years. And you saw from Professor Mathieu that despite all the efforts that we put as a community, the clinical outcome was not progressing as much as the effort that we deployed. So there is a fundamental question that we need also to ask ourselves. Do we really think that people with diabetes do not want to have a healthy life, do not want to have a very good quality of life? And I believe that we need to realize that beyond being agile and with a good speed. We need also to start from this point, and please, if you can progress, and realizing that diabetes is a very, very complex disease to manage. That is a 24/7 commitment. And despite the effort that healthcare system can put to provide time for the healthcare professional with people with diabetes, this is essentially 99% of their time will be alone. It's a self-managed disease. So we need to think about what kind of tools can be available to better manage this disease. On the other side, there is also the consideration that diabetes is extremely expensive. In Europe, they estimate 150 billion euros spent for diabetes. On the other side, 75% of this cost are diabetes complication related. And we can say that if we do a better job, we can save lives and we can save resource to be better reallocated. So you see already progressing. We need to invest to delay complication, and recently we also make some recommendation. We can delay complication, as I introduced, if we can invest for widen the access to technology and innovation in Europe. And diabetes technology innovation can dramatically improve the management of diabetes. They can provide to healthcare professionals and people with diabetes with better tools. These two recommendations that has been launched during a European Parliament event is about developing a policy promoting outcome-based diabetes care. And this recommendation was towards European policymakers, but also towards policymakers at national level. And the second recommendation was to promote clear and sustainable funding pathway for innovative treatment and digital health in diabetes. We believe that this potentially is a way to move forward, but also we know that no one can do alone. This requires the coordination of all the stakeholders that are gathering today in this very interesting symposium. And unity and collaboration really can create a more integrated, a more sustainable healthcare system, but also improve the outcomes and the life for people with diabetes. For this reason, we are extremely glad that European Diabetes Forum is now up and running. And as a FPA diabetes platform, we believe that in full respect of roles and responsibility, we can contribute to make a significant change towards a better future for people with diabetes. Thank you very much.
Thank you very much, Maurizio. And again, you came in with different angles, and I was especially struck also by something you said, that people with diabetes want good lives and want to be healthy. And that's a thing that we sometimes forget. So again, the voice of those living with this disease need to be an integral part of our European Diabetes Forum. And so we're very happy that through IDF Europe, we have been able to realize this. Now, let us go to the next speaker, and that is Ms. Julia Haagen from the Health Innovation Hub. And you will introduce to us, Julia, the Digital Healthcare Act.
Yes, thank you. Thank you very much, Chantal, for the introduction, and thank you very much for the kind invitation to speak and to talk about the Digital Healthcare Act and about how this is creating a reimbursement framework for digital health applications. I think I don't have to say a lot about how COVID actually has increased the demand for digital health, and I think the previous panelists have shown how it is important to actually find a way to sustainably sustainably provide digital services to patients. So I will try to give an answer to that for the case of Germany. First of all, on this slide, a few sentences about the Health Innovation Hub. So the Health Innovation Hub is the in-house think tank of the Federal Ministry of Health in Germany. We consult the ministry and other relevant stakeholders in questions of digitalization. We are an interdisciplinary team of 12 experts with backgrounds in law, in data science, in actually care, and as in hospital IT, and in pharmacy and other aspects. So we have been working a lot on this framework for the digital health applications. We call these digital health applications DiGA. So that's maybe a term you might have come across if you are interested in the topic. And next slide, please. I will briefly lead you through the procedure and define what a DiGA, so a digital health application, actually can be, what are the requirements, and what we expect from it. So a DiGA, a digital health application, is a medical device. It's a low-risk medical device, so risk class 1 or 2A. Either medical device regulation or medical device directive, depending sort of on the provisional rules. I don't want to go into detail with that, but it's a medical device of a low risk class. Also, a DiGA, a digital health application, has to rely in its main function on digital technologies. So it's not simple hardware device that comes with an accessory software, but the main function of the medical device, of the digital health application, has to rely on digital technologies. That may be software, but it may also have a hardware component. Then a DiGA, a digital health application, is intended to be used by patients. So basically, you have to imagine that it's something that physicians are going to prescribe to patients, just like they're prescribing a drug or some other therapy today. So the DiGA has to focus on patients, but it may also include the healthcare professional, the physician, for example, by facilitating the interaction or the collaboration between the healthcare professional and the patient. Lastly, with regard to what is a DiGA and the definition, it is limited to a certain set of functions or functionalities. Those are functionalities that are pretty standard with regard to medical devices. It's about detecting a condition, so diagnostics. It's about treatment, palliation, abatement of pain, compensation, etc. There are just a few functionalities that we know from medical device law that are excluded in this case, for example, contraception. So this gives a short overview of what a DiGA is. Let's move on to the next slide, because of course it's not only sufficient to show that a digital health application comes with the characteristics of a DiGA, of a digital health application, how we define it in Germany, but we also need to make sure that it meets the requirements that we have defined. So basically, there are two types of requirements. The requirements are checked by the Federal Institute of Drugs and Medical Devices in Germany. It's a federal institute that is in charge of this process. So a DiGA manufacturer or a company that is developing a digital health application has to submit the documents to the Federal Institute for Drugs and Medical Devices, and will then the documents will be checked for meeting the defined requirements within a maximum of roughly 3 months. So a brief look at the criteria. As I said, two types of criteria. In the left, in light blue, we have sort of the more general requirements, where we want to make sure that a DiGA meets requirements with regard to safety, functionality, quality, data privacy, and data security. So these are the fundamentals that all digital health applications have to meet whenever they want to pass this threshold and to become a digital health application that can be reimbursed by the public health insurance, the statutory health insurances in Germany. The second aspect, and that is of course even more important, is that the digital health application shows positive care effects. So it shows that either patient-relevant improvements with regard to structures and procedures have been found, or a medical benefit. You might ask yourself, what are structural and procedural effects? And yes, that is a legitimate question, because that's a new term that we have defined in Germany. Every one of you is aware of medical benefits and of how that is defined, but that category is a new category that we're going to look at in a bit. But first of all, one last important thing about this procedure. So there is the possibility that you apply to become a DIGA that can be reimbursed by the statutory health insurance if you meet the general requirements and if you show that you are able to collect the evidence for your positive care effects within 12-month trial period within the statutory health insurances. So that's the real novelty of this procedure as well, is that there is the possibility to join the reimbursement framework on a trial basis for 12 months. And then, of course, again, after those 12 months, you then have to show that you have the evidence of your positive care effects. Of course, this was a very, very brief overview, and I don't have the time to go into detail. But if you look at the website of the Federal Institutes for Drugs and Medical Devices, which is the BfArM in German, you will find information in English on their website detailing all the requirements, including a guideline document that replies to answers many questions and gives further advice. So now let's move on to the last aspect, which is one of the most interesting, is that the main requirement for a digital health application is to show positive effects on care. So there are two components of that, possibly. There's the medical benefit, something that you all know very well: morbidity, quality of life, mortality, something we have been using for decades. But then we figure that digital technologies, in many cases, can have an impact on other aspects of patients' life, especially in the case for chronically ill patients, which I think applies as well to patients with diabetes. It's about improving other aspects in their life. And for these structural and procedural effects on the left side of the slide, you see a couple of examples. So it's about reducing the burden of illness in daily life. So whenever your condition actually has an impact on your daily life, a DIGA, the digital health application, might actually be able to help you. Or the digital health application might be a sort of companion that makes sure that you stick to your therapy recommendation, that you go to all the appointments that you should go, that you have all the checkups that you need, and that you see all the different types of therapists that you should be seeing. It's also another positive care effect in that category might also be the access to care, because you might be waiting for appointments with a specialist, but in the meantime, you might be able to consult or to use a digital health application that can still help you in the meantime. And other aspects like patient safety or the coordination of care. So what we did here in Germany, and what we are very exciting, is that we are opening the range of positive care effects that digital health applications can have. All those digital health applications that meet those criteria, show in studies that they have the evidence, will be reimbursed by statutory health insurances in Germany, and physicians and psychotherapists will be able to prescribe those to their patients. And something that we're very excited about as well is that we incited that there's an incentive for both payers and digital health manufacturers to set up pay-for-performance models. So we will finally move to a pay for performance for an outcome-based reimbursement structure as well. And I think this is something that can have a very positive impact on care for diabetes patients as well. And that's all from me for this time. Thank you for your thank you for listening. And we have lots of information on our website, some of it in English, not all of them, but have a look if you're interested in the topic. And I'm looking forward to the discussion. Thank you.
Thank you very much, Julia. And, I'm notorious for going rogue and not sticking to the rules, so I'll do it again. I mean, we have several questions here coming in. So, Julia, just a question to you. Are there any diabetes app management apps already in this process?
So far, we don't know yet. The process.
It's brand new, huh?
Yeah, the process is brand new. The application process has started early on in summer. So we expect the first digital health applications to be able to be prescribed to patients by probably next week or in October, roughly. We don't know yet if there's going to be a diabetes an application that is relevant to diabetes patients, but I'm pretty sure that there are going to be some. A few of those who are already in the field of diabetes have announced that they are at least striving for it, or they want to become a DIGA. But in the end, of course, it depends on the fact if they are meeting the criteria and if they can provide the evidence or the evaluation concept that they will be able to collect the evidence within those 12-month trial period.
Yeah, and then another question, I guess all your strategies will also be looking at GDPR compliance of the DIGA that is proposed?
Yes, of course. That's one of the very, very important aspects. That is actually one of those, the data privacy and information security or data security is one of the fundamental aspects that is being checked for all DIGA. And actually, there are even some requirements that are stricter than GDPR. So yes, that's very important.
Okay, thank you very much, Julia. And so we have heard Germany, how they are playing around with this digitalization and novel technologies. And now we move to France as another country example. Again, already also discussed at this year's EASD annual meeting, the project ETAP, Experimentation of Telemedicine to ameliorate the healthcare paths in France. And it is really an honor again to introduce a friend of mine, namely Professor Charles Tivolet, who is also the president of the French-speaking Diabetes Society, SFD. Charles.
Thank you, Chantal, for your introduction. And also as a president, I will really have the very strong hope that SFD will join the EUDF very soon as a very active member. As you mentioned also, I'm very proud to speak about the experimentation of telemedicine in France. And in the next slide, you see that telemedicine has been a very important subject of the French health government for these last years, and with several impacts, with experimentation for patients with chronic disease. And 5 diseases have been characterized to benefit from these telehealth monitoring, namely cardiac heart failure, kidney failure, respiratory failure, diabetes, and also arrhythmia. So I will speak about that. But also there was some big interest in teleconsultations. In the next slide, this ETAP program have several similar frames. First, to define a target population in order to be very precise, but also to limit the number of patients to benefit for this system for the social security, since there are some money problem. Technical requirement in order to exchange data between the patients and the professionals, pricing packages, but also several necessity to monitor, educate, and evaluate the system after 6-month period. The main objectives were to first to reduce the number of recurrent hospitalizations, and also to have some indicator for disease control, or even then some improvement through the rapid access to specialists. There was also some interest in the improvement in the patient quality of life, and also improvement in care and efficiency. There were, for this program, some financial supports, but as you will see, this predominantly concerned the electronic systems. On the next slide, these are the figures of the inclusion in the program. The line concerning diabetes is in red, and the line for cardiac health failure is in blue. As you may see, the inclusion was increased between September 19 and June 20 by 81% for diabetes, but this increase was much more evident for cardiac failure. Concerning diabetes, the target population were people with type 1 diabetes above 18 years of age, which HbA1c above 8%, or between 12 years of age and 18, with HbA1c above 8.5%, or within 6 months of introduction of insulin after diabetes onset, or for people with type 2 diabetes with an HbA1c above 9%. And if you click on the slide, you will see that the inclusion for telehealth monitoring for people with diabetes were slow at the initiation of the program. This may be explained by the limitation of the financial support to the healthcare professional. As you may see, 110 euros for MDs, 60 euros for nurses, as they do mainly of the job of the monitoring, but only 16 euros, and 370 euros for the technical system. And this was the sum every 6th month per patient. There was some quite complex administrative issues in France to launch the program, and these programs were mainly hospital-based and not in the care, the primary care physicians. They did not include at the beginning CGM or FGM, and so that was also a problem in limitation, but this was changed during the program. And the inclusions were clearly increased during and after COVID confinement. On the next slide, you will see that the COVID lockdown clearly showed that there was a need to develop the telemedicine to maintain the contact with the patients. But we were faced to a limitation in the organization with the limited numbers of healthcare professionals that were dedicated for outpatient care, since they were really very busy for inpatient care. The need at this time to constitute platform with dedicated and multi-professional personals, including MDs, but nurses and also dietitians, that were very useful during this period. And there is one also consequence that we were faced to, is the necessity to obtain both insulin and glucose data using interoperable system. If we have only glucose data, it's not so pertinent for diabetes care. On the next slide, after the COVID crisis and after several months, we were faced to the necessity to go on with the telehealth capacities. And there were two main objectives: the need to maintain access to care, but also the protection of healthcare professionals and patients. And so the different associations and the SFD were just to define and help to define the list of derogations according to professional and patient association that there was no need to put some HbA1c level to be included in the ETAP program. And so this was a very important issue. The first step was focused to COVID plus patients, but this was rapidly extended to high-risk subjects and including those with diabetes. There was also a very good reimbursement of all teleconsultation. And so we switched from 10,000 teleconsultation per week before the crisis to a peak of 1 million teleconsultation per week. And so now we are close to 500,000. So we see that clearly the way to monitor patients have changed completely. There was also the reimbursement of nurse and dietitian care for patients at home. That was also a very important issue. On the next slide, and I think it's my last one. So what can be learned and be expected for the future in the French landscape? We see that telemedicine is now clearly integrated in the care, but it's a time to transform the experimentation into ordinary care solution. And this need to reconsider the financial support and to increase the sum for healthcare professional. So this is the present discussion with the ministry in order to be able to strengthen this solution. Also, the COVID-19 crisis has clearly illustrated the importance to reorganize the healthcare system and the healthcare pathways. So we have to reconsider small system that integrate the care and in the different way. There are urgent needs to standardize tools with interoperative platform for glucose data, pens, pumps, additional information, nutrition, activity for optimal follow-up. We have to move up to complete integrative platforms. And all companies, we think, involved in diabetes care should integrate this open world and to facilitate data management by healthcare professionals without financial consideration. And this in France is really an issue. So I thank you for your listening, and I'm be ready for question. Thank you.
Thank you very much, Charles. So to what extent were people living with diabetes involved in really making this project?
Well, they were very active in the system, and there are some federation. The French Federation of Patients is also very close to the discussions in order to promote this access to this form of type of care. So really, patients are very willing to integrate these solutions.
Yeah, and I heard keywords like integration and also this multidisciplinarity with different professions who also need to be integrated in the system.
Yeah, that's right.
Yeah. Okay, thank you very much, Charles. So after Germany, France, we now go to Romania, where Dr. Bogdan Timar from Timișoara will again show us how in Romania, with a different angle, they have again worked together with the regulators, with the payers, to really bring in digitalization, telemedicine for people with diabetes in the context of this COVID epidemic as an accelerator, if I may say, Bogdan. So the floor is yours.
Thank you very much, Professor Mathieu. It's a great honor for us, for the Romanian Diabetes Forum, to take part in this symposium, the EUDF Symposium from the EASD. Well, in my short talk, I would like to bring in the spotlight a tool developed for patients with diabetes, which was a real success in Romania. In fact, it's a nationwide telemedicine platform designated for each patient with, which needs this kind of tools for help during the pandemics and hopefully even after the pandemics. However, even if I'm going to talk about this telemedicine tool, in fact, the key message is related to another important part. The highlight of this message is that the fact to create this kind of tools in a rapid manner, which are successful for our patients with diabetes, there is a need that all the stakeholders are participating in this effort. And I think the key message now here is how all the stakeholders were engaged to deliver this kind of tool and improvements in the care of the patients with diabetes, because to have such a rapid intervention for the patient with diabetes in Romania, we have engagements from the government, from the national medical insurance company, from the management of the hospital, from us, the doctors, of course, from the patient, and also from the media. So I would kindly ask you to scroll through the next two slides, because the second one is in fact just my disclosure side. And I'm pointing to a very important thing, and it's a first step to the success of this issue. Now I would kindly ask you to go back to the second slide, because this is just my disclosure one. Well, the first key point in the success of this initiative was the role of the government, because in less than 1 month, in fact, after just 18 days from the first case reported in Romania, the government and the president of the Romania decreased the state of emergencies. The next slide, please, which had, of course, a set of measures for the entire life in Romania. As you can see during this slide, in just 1 month after the first case, we had a rapid response from the authorities, we have had a rapid response from the government, and we also had a national lockdown for 1 month, which was a key of the success of the next intervention. The next slide, please. In this measures designated to reduce the epidemiological risk, we've had a large set of instruments designated for the patients, and I'm talking about general measures for the patient, but which had a special role in patients with chronic diseases as well as for patients with diabetes, because at about 1 month after the first case reported in Romania and during the state of emergency, the government released some set of tools for us. Well, the first one, and a very important one, was that for a consultation there was no need for the health card of the patient. Other measures, very important, were that patients can be consulted using telemedicine tools, and all the telemedicine consultations were recognized by the government. And a very important thing again was that the prescription could be sent using e-tools to the patient. So even if they've had the messaging tool on their smartphone, the doctor was able to send a medical prescription and another person could take the prescription from the pharmacy. Well, just after this set of measures which were released by the government, we've set up a national telemedicine tool designed for each patient from Romania which needed devices remotely from the doctor. So just after 2 days having this kind of measures released by the government, the platform, the telemedicine platform, was online. And as you'll see in the next slide, this telemedicine platform was in fact just at the beginning of the plateau. We know that this kind of prevention against COVID-19 is very important for each and every patient. However, we know that the prognosis of patients with diabetes is much worse than compared to the general population. And in the next slide, I'm going to show how the telemedicine tool was released just at the beginning of our plateau. So after this set of rapid and firm measures from the government, including here the approval for use telemedicine in all the patients, we've had a plateau which was at a steady state of about 300 up to 500 patients daily. And it was, the prognosis of the pandemics was quite good. Unfortunately, at the end of this plateau, in 15th of May, there were some political pressures and the state of emergency was abolished and it began a state of alert and relaxation measures, which led to further deterioration and even catastrophic outcomes regarding the number of patients having right now. What we've done during this telemedicine tool, in the next slide, we're going to see that we've had a set of intervention. We've offered this kind of telemedicine tools for each patient needed in Romania, this kind of consultation from a doctor specialized in diabetes. In this tool, we've had another set of sub-tools like video conference, a platform for sharing documents, sharing reports from CGMS or sharing lab results. We've had a permanent call center and also responses using emails. I would like to scroll through the next 3 slides because the next 3 slides are just showing how this kind of tool could be accessed by our patients. And in the next slide, we can observe that this tool was used by all types of patients. Even if we are going to talk about the age groups, we can see that patients from all the age groups use this kind of tool. Telemedicine was used merely by women as well as men, but in a smaller proportion. And in the next slide, we can see that people from the entire country and not only accessed this telemedicine tool. So, for example, in a regular random day chosen here, we can see that in one day we've had more than 200 telemedicine consultation using just this platform, and these calls were coming from the entire country, and even we've had 5 calls coming from Vienna. They were Romanians living in Vienna, but they were accessing these telemedicine tools for patients with diabetes. In the next slide, we are going to see that the platforms used were mostly coming from the smartphones, and that's why our next step is going to be to develop a smartphone application dedicated to the telemedicine solutions for patients with diabetes. In the next slide is going to be presented how this kind of scenario was integrated. So the first measures regarding the reduce of epidemiological risk were successful ones, including here the telemedicine systems used here. Unfortunately, after the relaxation period, we can observe that we are reaching a new plateau, and unfortunately, today Romania is on a new record high number of cases. We are about at 1,800 cases. Lastly, and I think this is the key message of the presentation, I can summarize that this kind of successful tools to be obtained in a timely manner for our patient have to have the participations of all the stakeholders. We observed here that this kind of tool, which was up in just a couple of days after the first cases in Romania, was possible only with the strong cooperation inside the Romanian Diabetes Forum between all the stakeholders, as I've said in the beginning of the presentation, between us as doctors, between the government, between the house insurance company, between the patient, and of course, using the tools from the media to disseminate this message. I think this kind of telemedicine tools and digital tools are coming during these pandemics, and they are somehow accelerated by the pandemics, and hopefully we will be able to use them to enhance the quality of care in our patients even after the pandemics. Thank you very much for your attention, and if there are any questions, I'm here to try to respond them.
Thank you very much, Bogdan, again for showing how you exploited this digital solution in your how can I say it, in your experience of COVID in your country. There is a question by Kyle Jacques Rose. Kyle, I transmitted it to Professor Matthew, so I'm sure he will take it on during the debate. And then there's a remark by Elisabeth Dupont of EUDF Europe, where Elisabeth reminds us that there is a survey on their website on how people with diabetes live through the COVID epidemic. So a warm invitation by Elisabeth to go to the EUDF Europe website and participate in this survey. So, David, I promised that you would have plenty of time for your debate. So I'm extremely happy that I can now hand over to you so that we have time for ample questions. David, and I'm so happy that my name will be under your face.
Well, we sort of have the same surname, so that's all right. We move into the second part of this program really now, which is much more a discussion part of what it is that we want to say with the EUDF. And we're really lucky to have 4 spectacular speakers to take us through this. And we've asked them just to give us a few slides about what it is they want to say. But beyond that, we will then have a much larger discussion to just cover a lot of the questions that bubble up from so much of what it is that you've been hearing today and thinking about some of the problems and some of the successes. So we start off with this discussion session with Bastian Hauk, who is the director of EUDF Europe, a founder of Crosshatch DDoc, and a board member of the German Diabetes DE. And Bastian is going to talk to us about what it means living with diabetes in times of COVID. So, Bastian, if I can hand over to you, and the floor is yours.
Yes, thank you very much, and I hope you all hear me all right. First of all, a slight correction. I am not the director. I am one of several directors of EUDF Europe, which is just another term for the board members there. Before I start, thank you very much for having me here, having me as a person living with diabetes and having me representing EUDF Europe as the European patient voice in diabetes that now also joined the European Diabetes Forum. We are very happy about that. I was given the task to talk about how does it feel living with diabetes in times of COVID in 2 to 3 minutes. I could make this very short and I could give that to you in one sentence. And I can tell you how I felt, but this is also what many people with diabetes out there have said on social media in our communities throughout. For me personally, COVID made me feel like a patient. It made me feel like a patient again. And for those of you that now nod their heads or shake their heads and think, well, what's so special about that? Because they maybe think this is normal, let me tell you it's not. Because this is what all of us living with diabetes out there do, and what I hope all of us should do even more. We should not ever let diabetes define us. We should not ever have any chronic condition define us. I don't think anybody does. Because here's what it is, right? We are all the people out there living with any condition. We are fathers, mothers, brothers, sisters, wives, husbands. And in our case, diabetes is just another family member. Maybe not the nicest one, but this is how we go about our life. Diabetes is part of what we do. We are not diabetics. We are a person that's also living with diabetes. But COVID, for me personally, and for many people out there, changed that for, I hope, a brief moment in time. But personally, it really made me feel vulnerable. It made me feel almost scared, and I'm not someone who gets scared much. And let me tell you why that is so. It was, I think, due to this whole lot of uncertainty that we're not used to, because usually diabetes is very well researched, and if you want information, you can find it somewhere. But with COVID suddenly hitting, there was a lot of strange communication about this relating to living with diabetes in times of COVID. And there was a lot of uncertainty. There was very little reliable information, especially in the early days. Now, FPA and the European Diabetes Forum, hopefully will join that, was very good in responding to that, but it took a while, right? It took a while. It was good information, but not right there when this first hit. Pharma and Medtech and the companies were very good in reassuring us about supply chain certainty, that there would be no, lack of insulin that would hit us, especially not immediately. But that kind of information coming from corporates doesn't necessarily reach the broad population out there. We're not on your newsletters, right? Patient organizations, this is where I want to reach out to. Patient organizations such as the member organizations of EUDF Europe played a super important role in jumping on that very, very early and providing context, making sure that people understood that not everything in mass media was right, and that some of the information was maybe over or under interpreted and should be put into context. And thank you, Chantal, mentioning that survey that EUDF Europe is just putting out. You will feel that reflected in there. Please do take part. Another very important role was peer support. I cannot ever stress that enough. Peer support, meaning people with diabetes, especially through social media, where suddenly face-to-face meetings and peer support groups in real life were not possible anymore. Social media and peer support was super important for giving mental support, social support. I don't know how many hundreds, if not thousands, of virtual hugs I sent over the last months and received, and those were really, really important. To move a bit away from that scary part and that vulnerable part and that feeling like a patient again, very quickly about the opportunities. Tanya Valentin mentioned the paper on Medtech that Medtech Europe did on opportunities in digital. I was very happy to be able to contribute to that together with my great colleague Katharina Braune from Charité, the two people living with diabetes, but she also being an endocrinologist. There are a lot of opportunities in telehealth, in digitalization, etc. But let's break this down into what this means. And let me again be very personal here, because we all talk about these great buzzwords, telehealth, digital, apps, DIGA, whatever it is. It's not rocket science. Sometimes things are so simple. Let me tell you what this meant for me. I left Berlin because I felt very depressed in that city, not being able to leave my small flat in the center for weeks and weeks. And I have since mid-May been in Copenhagen, Denmark, and I'm currently joining you from my boat. So you can see in the background, I'm sitting on my sailing boat in a harbor close to Copenhagen. Now, where does telehealth and digital come in? Let me tell you, I just had my first visit with my diabetes nurse and my doctor, my endocrinologist, 2 weeks ago. I uploaded my data from my CGM to the cloud. They looked at it before meeting me, and we had a Zoom call just like this one. That's telehealth for me. It's a very small thing, but it's super important. Here's what's more important. I will hopefully be able to continue to do this once I'm back in Berlin. And you know what? My endocrinologist is less than 5 minutes walk away from my door, but I would love that this continues, because there was a statement about the death of the routine visit. I don't think that's true at all. I think what we call routine visits, that will change. It'll change dramatically. But if you listen to what people with diabetes out there are saying is, we want digital, but we also want personal. We don't only want personalized digital, we want both, because
Bastian,
we need time with our healthcare providers.
Bastian, can I come
I'm
in
out
here?
of time.
To say, look, I think that's a really good point to end your particular input so that we can move on to discussion, because that particular point, I think, might well be taken up by Rita, who's our next speaker coming from the Federation of European Nurses, a research fellow with them. And if we can then bring Rita in to look at the impact of COVID-19 on diabetes nurses and the way that that influences patient care, I think that would be excellent. So, Rita, can I just hand over to you now?
Thank you very much. And if I could have the first slide, please. So my name is Rita Ford, and I'm a diabetes nurse and a FEND postdoctoral research fellow at King's College in London. And I'd like to thank you for the opportunity to share with you some data from the FEND COVID-19 survey, which was conducted as a collaboration between the Foundation of European Nurses and Diabetes and the diabetes team at the Faculty of Nursing, Midwifery and Palliative Care at King's College London. And if you could animate the slide, please. And as FEND celebrated its 25th anniversary, it was wonderful to be able to draw on their vast network of diabetes nurses across Europe. And we were able to include nurses from 22 countries in this consortium. So, and if you could animate the slide, yes, the next slide, please. So this survey was distributed amongst the 22 countries that were a part of the consortium. And if you could animate the slide, please, just 2 or 3 animations in this, and you can put them all on and I can work through them. So the survey was disseminated initially between amongst the 22 countries, but it was also taken up by diabetes networks in 5 additional countries. The survey was established and developed, in English and then translated into 16 additional languages. So from this distribution, we were able to include the analysis of 1,666 responses to this survey. And I'd like to share with you now on the next slide some of the responses in relation to the participants and the information they provided to us about the extent of the disruption to diabetes services during the pandemic. So if you could animate the next point, please. So what the respondents have reported is that the care to people with diabetes was disrupted either quite severely or extremely, and this was reported by almost 47% of the respondents. Self-management, a third of the respondents indicated this was severely or extremely disrupted, and 2/3 of the respondents indicated that the provision of diabetes education was severely or extremely disrupted. Now, in relation to the technical support, while most indicated some disruption, there was just over 20% indicated that this was either a severe or an extreme disruption. And importantly, 1/3 of the nurses indicated that the psychological support provided to people living with diabetes was quite severely or extremely disrupted. The next slide, please. So in relation to how nurses reported they contacted their contact methods for people living with diabetes prior to the pandemic, we can see that they ranked this from most to least common, and face-to-face consultations were ranked most common. So if you can animate the slide for me, please. And during the pandemic, if you want to animate again, please, we can see that there was a shift towards virtual consultations, in particular telephone and email contact. And if you can animate the slide, please. Sorry, the next slide, please. So in this slide, I'm going to share with you some extracts of the data that the nurses provided in terms of free text of the challenges they experienced in relation to the services and resources of working with people during the pandemic. And if you can animate the slide again, please. And here we can see that one of the respondents indicated that it was really challenging to quickly find new and safe ways of conducting consultations. And I think this is really important. They indicated that there was little support to this shift to a complete virtual management working with people with diabetes, and it was challenging to determine the urgency of consultations during the pandemic. The respondents also indicated some opportunities, and one of these opportunities was in relation to governmental support. If you can animate the slide, please, to access equipment to actually conduct video consultations. Others saw it as opportunistic to introduce new digital services to their arsenal of how they manage and help people live with diabetes, and others saw it as opportunistic and beneficial to be able to remotely access data and conduct video consultations. And the next slide, please. The respondents also indicated the physical and psychological impacts on people living with diabetes in relation to the COVID pandemic. And as we can see from these data, the respondents indicated that there was a significant increase in the physical impacts of the pandemic on people living with diabetes. And whilst only 17.5% of the respondents indicated a significant increase in foot complications, we do know that the legacy and the sequelae of that, and that has recently been borne out in some Italian data. We've also, our data also showed that almost half of the respondents indicated a significant increase in depression amongst people living with diabetes. And if you can animate the slide for me, please. While 2/3 of the respondents indicated that there was a significant increase in diabetes distress. And if you can animate again, please. And the majority of the respondents, over 82% of the respondents, indicated a significant increase in anxiety amongst people living with diabetes during the COVID pandemic. So as our data have highlighted, there has been a significant physical and psychological increase in the risk to people living with diabetes. And these data suggest that we urgently need strategies to ameliorate these, and these strategies need to be sustainable, but they also need to take into account the psychological and physical risks to people living with diabetes in such a pandemic and going forward in future pandemics. And I would like to thank all of the nurses who were listed here on this final slide who participated with the development and dissemination of this survey. And I would like to thank FEND, the Foundation of European Nurses and Diabetes, for their continued support to diabetes nursing and in turn to people living with diabetes throughout Europe. Thank you very much.
Wonderful. Thank you very much indeed, Rita. Brilliant overview of that. And I think really highlighting the extent to which COVID is influencing the lives of people with diabetes. And we really need to take that extremely seriously. Now, we move across now to Xavier Kos, who's the chairman of the Primary Care Diabetes Europe organization. And he's an associate professor, and he's going to be talking about the management of COVID in those with type 2 diabetes, the elderly, and those with complications. So, Xavier, just give us an outline of this, and good to have you with us.
Thank you. Thank you very much, Matthew, for your invitation and for the EUDF initiative. I just would like to share with you that, yes, it's true, the COVID-19 has been a big challenge for the primary care family and for all the community. And I think that since March, primary care is really centered in providing care to the COVID-19 persons we are trying to be detecting and caring in the primary care centers across Europe. We know there's what happens with the normal service we used to provide to our persons with diabetes and other chronic diseases. There's a, I mean, in my opinion, we see that this is like we stop providing the normal follow-up to that person, so that follow-up has been to be postponed, and now that is we are facing in this second wave now in Spain and in other countries across Europe. We are at the same time have to be providing care to these persons, and at the same time try to provide our care for the COVID-19 patients itself. So this is a big challenge, and that it means that also during that period, diabetic persons, we have to attend them in their acute reasons for contact, and also and that, of course, we've been postponing those ones they just came for us for follow-up. And of course, that delay in terms of what of this care has been to be analyzed, what is the impact. We are observing some aspects in terms of that delay. We have seen an increase in terms of food problems and other chronic complications. But I think just it's important to share that I think that authorities, healthcare professionals, citizens, and the persons living with this chronic condition like diabetes have to adapt to the new reality we are living, and that it means a transformation of how we are delivering, how we are providing care. And I think that is very important because, and I consider that as an opportunity. I consider that any crisis as an opportunity to improve. And I think that this is an opportunity to change how we are delivering care. And this means an opportunity to transform. And I would like to share to transform in different pillars. And I think that it's in my opinion, it's important to know we have to transform how healthcare professionals, how the system is organized to provide care. And that it means, in my opinion, to try to look for what is the good contact, the ideal contact we have to provide to in each situation. We have now like a kind of menu of possibilities we have in the primary care, face-to-face contact, very restricted, but we still have. Also telephone calls, we have video calls, SMS messages, email. And so how we have to adjust the complexity we are facing to this kind of menu of contacts we can provide to our citizens. In terms of opportunity also for these persons living with the chronic condition, because I think that till now, at least in my opinion, in the primary care, sometimes we are dealing, we are providing a care that is still somewhere is really paternalistic. We have to provide more. We have to empower more our patients living with that chronic condition, the persons living in that chronic condition, and they have to be more responsible. We have to support them, to coach them there to be more responsible of the management of their disease. In terms of the society, is also an opportunity because they have to be also responsible to use the healthcare services more correctly and in a more appropriate, consider and appropriate connected with the complexity. Of course, if we are just trying to provide answers about how we are dealing with that, with elderly persons, how we are dealing with those persons with complications, we are already we have in the electronic care systems we have like kind of indicators that could allow us to stratify what are the kind of of persons we have to prioritize. And I think that this is the systems, this is this kind of artificial intelligence that is trying to match all of this information that is inside the electronic clinical records, have to provide support to the healthcare professionals in terms to prioritize what are the persons that require more attention and what is the kind of attention they require, a kind of a smart agenda that could support and coach healthcare professionals, nurses, and GPs on that. So okay. I think, yes, so I just finalize with this last remark. Thank you.
Okay. No, thank you very much. It sounded as though you were coming to the conclusion. Sorry to cut across your final sentence.
No.
I do think it's one of the really important things, actually, and I think that it's bubbled up here as to what is the best way of using these electronic systems, because even on the radio very recently, someone was just saying, please pick up the phone and talk to people, not just email. There is something very special about the necessity to do that. And I think that in our electronic age, we sometimes think that email and those sort of things can do everything. Yes, do come back in, Xavier.
Yes, I think it's very important also to take into account what are the expectancies or what are the persons expect from this new way of communication. And we as healthcare professionals, we must be very fit how to communicate in a good way. It's not the same to be in a face-to-face contact. And when you're doing...
We'll come back to this,
okay,
Xavier, because I think we're lucky now to have Christian Bussoy, who is a member of the European Parliament. And he is, in fact, the rapporteur of the EU for Health programme in the Parliament. And so, Christian, it's really useful to have you here as part of our discussion, and be lovely to hear your insights. So let's just hand the floor to you briefly to hear your perspective.
Thank you so much. Thank you. I am also happy to be part of your event and also to share with you a little bit what will be the next EU for Health program, but also the synergy with the digitalization and the digital solution for health. Thank you once again for inviting me to take part at the European Diabetes Forum Symposium today. I'm a member of European Parliament since 2007 with a short interruption 2013-2014 when I was the president of the National Health Insurance House in Romania, and I had the chance to implement the electronic health card in Romania, and also with the help of European funds, the pilot project of Romanian electronic health record for Romanian patients. Then in 2014, I came back to European Parliament, and most of my activity since 2007 was to work in the healthcare area, try to improve the healthcare systems across the Union. Innovation in research, progress towards digitalization of the healthcare sector, improving health infrastructure by turning digital, will facilitate better healthcare and access to healthcare for our citizens foremost. And of course, will make our healthcare systems more resilient, which is a very important issue, a very important objective for the medium and long term. A growing number of digital programs and in-health tools are proven to improve health and lower the cost of care. I'm not only the rapporteur for EU for Health, which will be the next health program of European Union 2021-2027, much bigger than the previous programs. Of course, not as ambitious as it was initially proposed, and we are all disappointed on the cut on the budget, but it will be a very ambitious program. I'm also the ITRE chair, the president of Industry, Research and Energy Committee, and in both these capacities, I'm working on finding the synergies and concrete actions with the aim of reaching the full potential on enabling the digital transformation of health and care in the digital single market. We have now the crisis, the COVID-19 crisis, which of course brings us a lot of unhappiness and a lot of problems. But beside the very negative things that are now in our lives, at least this crisis shown the need of digital tools and services in order to have the continuity of care. And also, this crisis shown us the need to maintain access to essential goods and services in times of crisis. Moreover, in the modern society that we are living, we need to adapt to the modern and innovative healthcare world as well, enabling health, not just delivering care. With the high prevalence of patients suffering of diabetes, patients who use digital health technologies can benefit greatly from both short-term health improvements and long-term health self-management. At the same time, healthcare landscape could also benefit out of digital health innovations in diabetes prevention too. And we have not only EU4Health program for that, but also Horizon Europe, where there are a lot of opportunities in order to research and to find out new modalities to prevent diabetes using the digital technologies.
Okay.
Finally, as you know already, as a direct consequence of COVID-19, the EU proposed many other initiatives, and also we have at our disposal the Resilient Fund, the next generation. And here we could use opportunities in order to develop e-health, mobile health, telehealth in synergy with Horizon Europe and the Digital Europe program. Thank you so much.
Christian, that's really wonderful to have that proper European parliamentary input to this. So thank you very much. So thank you to all of those four speakers, to Bastien, Rita, Xavier, and you, indeed, Christian. Now, one of the things I'd just like to throw open to the four members, first of all, of the second half, is what is the real block to getting so much of this running? I mean, one of the blocks that we've got in the UK, for instance, is GDPR. And I noticed someone, Rami Fikri, also has flagged up in the questions about who owns the data for all of these devices. And GDPR is one of the problems that we have, where however smart you are technologically, there's somebody always coming along and saying, no, you can't do this because the data is private and we can't manage to transmit this. So I was, maybe Rita, you could address this and then move it over to Xavier. What do you think about the general data protection?
Yes, thank you for this. And I think that's something that we actually do need to consider. However, the data from our survey would suggest that whilst we're thinking about data protection, we actually also need to think about access, as many of the nurses who responded actually didn't have the facilities to conduct remote consultations. They didn't have webcams. They weren't able to have video consultations. So whilst it's important we do think about GDPR, and that's fundamental to any digital technology we use, we need to think about the resources that nurses can access. And also, just in mind of the pandemic, from our survey, we do know that over a third of the nurses across Europe were redeployed to non-diabetes specific areas during this pandemic, at some point during the pandemic. So in terms of skill set, in terms of access, I think, we need to consider those in line with GDPR. And I think,
let's move across and keep specifically to the GDPR, because I think you've made that particular point about the psychology. Let me ask Xavier, and then actually I might go back to Julia, talking about DIGA as to what their solutions are.
In terms of security, here, of course, it depends of the area, but here, what I can explain or share with you is experience in Catalonia. All citizens have to go for a kind of sign approval to access to these files. So, and also all citizens have access to their clinical records, lab tests, etc. So, I just to confess that COVID-19 accelerate all the process to facilitate the access for health healthcare professionals and to have a good communication being with healthcare professionals and citizens. And that allow us for the first time to use video consultations that we start using in April this year. So this is, of course, COVID-19 accelerate all of these processes, but of course, all the system is encrypted, secure, okay, and we are now can use it in a more fluent way. But yes, this have some barriers before to be implemented.
Julia, have you got a comment about that? Just unmute yourself before you speak.
Thank you. Well, I mean, I can only agree. I think it's so for the digital health applications, it's not so much. It cannot exactly be compared to telemedicine, but of course, in both cases, we need to make sure that data privacy and data security, that's a must. That's nothing we can discuss. And I think but that's also something we've seen in the discussion. So I really fear that I'm only repeating what has been said by all the great panelists, is that for it to work sustainably, and I think we've seen that in several examples, country examples and statements, is that we need reimbursement models that work sustainably. Maybe as a very short point.
Yeah. And then just on the issue of the point that Rita was rather bringing up parallel to GDPR, there's the whole of the psychology of this. And Bastian, it sounds as though from your perspective that this has been really one of the biggest problems. And I don't know whether you've got a view about the sort of technology that we should use. I was very impressed with the whole suggestion that we need to be, that Xavier raised about, really, really concentrating on what is the best electronic way of doing these things, because some of it is mathematical and digital, easily mathematical and digital is what I mean, where you've got a lot of numbers, hemoglobin A1Cs and all the rest of it, and that can be done almost by AI. But the other aspects, the psychological aspects, Bastian, looked as though you were having considerable trouble with. Again, unmute yourself before you speak.
Yes, thank you. I don't think I would say I have trouble with any of that. What I would like to say is, and that is true for GDPR as well as for the social aspect of things, is digital needs to be done well. And the question is, how do we do digital well? And the easy answer to this is don't design solutions for us, design with us. The same is true for GDPR rules. Most of these rules, most of these laws are written by very healthy young male, usually lawyers. These should be written including people with diabetes, including people you find on the streets. If you do inclusiveness in everything you do, then you're on the right path to do well. And that is for all the aspects you were just mentioning, including the social and psychological one.
Christian, if you're still here, I think that one of the questions that we'd like to come back to you is a question that was raised by Maurizio about how fast we can get this done. Because again, one of the problems that we face is that in theory we can do all of this. Everyone can sit down with a pen and paper, say, wouldn't it be great if? But there seem to be a lot of endemic delays with all of this. So, Christian, have you got a view about that? And maybe we come back to Maurizio as well, just to have an input into that.
Well, I had a short problem with the connection. That's why I didn't follow all the questions. And at some moment, I'll have to go to another meeting. How far we are from enabling digital services for diabetes patients? Well, not very far. Not very far, because of course there is now the last discussions about the budget, about setting the framework. It's clear that we are still some months or maybe years in some member states in order to have everything in place. But for me, the direction is very clear. Health will be really a much greater priority in the coming years, also due to coronavirus, and everybody is conscious now that we need to work together at the EU level. And the digitalization of EU economy and also of the health services was already an important strategic objective even before COVID-19. So when the new European Commission took the job, and with the support and agreement of the Parliament, you know that we decided together to have two strategic directions for the next decades. One is Green Deal and transforming our energy, our agriculture, our industry, our transport systems. And the second was the digitalization of our economies in order to be more competitive. And that's why Commissioner Breton, Commissioner Vestager, and all the Commission came with all the communications on management of data, artificial intelligence, and digitalization. And now things are going even with a high speed. I spoke yesterday with the Director General from DigiConnect, Mr. Viola, about the digitalization of health systems, and he told me that on the resilience projects, digitalization in health has the highest ranking. So national governments which are asking money from the resilience instrument to digitalize their healthcare systems, and of course the solutions for diabetes could be part of this, have the highest chances in order to get this money. Of course, there are still member states where the need is not so much, and we have to work together, we have to put pressure, we have to lobby. That's why it's extremely important, the issue that you are discussing today. But I am quite confident, and more confident, that I would be at the beginning of this year if we had this seminar, this discussion in January, let's say like this.
Good. Well, that's really cheering to know. Now, so then the other problem I think that we've got with electronic stuff is that we generate a lot of data, and this all pours into some computer somewhere. And Charles, if I can just ask you one of the questions, and then I'll come on to Tanya as well with the same sort of question about, yes, but who's at the other end of all of this data? I mean, it's no good having data pouring into repositories and electronic memories. There has to be somewhere along the line that there's a proper return of information, because it's all very well, you know, there are some things that you can do yourself, which is that you can measure your own mean hemoglobin A1C over the months and so on, and a computer and a spreadsheet will do that. But somebody has to be at the other end of a lot of this. And do we have enough person power to do that? And again, Tanya, I was astonished by the extent to which you have got so much enthusiasm for this, and was fascinated by you pointing out that the biggest taxi service doesn't own a single taxi. But I think we're in a different situation where if we have medicine without a single doctor or nurse, we might be in trouble. Anyway, that's from a moment, Tanya, for you to think about. Charles, where do you think we're in the business of who's at the other end?
Well, this is the main question, because when we have all this app world with plenty of indicators for the person with diabetes, the main danger is to remain alone with all this data and to have a complete integration of this data. So it's really important to think about what are the structure of the person at the other end of the connections. So I think that's really, it's a main important subject, not to transfer this data to commercial agencies or GAFA and systems. That these data need to be remained into the healthcare professionals, and to have some really care issues and not financial issues. So it's important to raise these points, and also to drive some new modification of the healthcare systems. And so in France, there are some way to go outside the hospital, but this is really a problem, because this is a very important financial issue.
Yeah. Okay, well, let's just move over briefly to Tanya before handing back to Chantal. I think, Charles, what you're saying is that there's a balance between the personal and the data aspects of these, and I think that's reflected in the fact that I think I can see a chemical balance in the background of your office there. Tanya, you I think said the death of the clinical appointment.
Yeah, it was not me saying it, it was reported in the interviews we had. And indeed, there's different views and we had in-depth discussions. We have a webinar which will look at how do we come from plans and ambitions to implementation. So a doing event about everything which has been identified as key findings, and the clinical appointment, how it really will look like. It will not be the end, it will look different, and we have to define how it will look different. So we have to unpack that. I don't have the answer, and I think we have to do that again in a joint discussion together. What I want to mention as well is how to come from plans and ambitions to implementation. I think people state that there's two important contributors which need to be at the table, which is the regions of member states who organize healthcare and also the payer community. So I think they also have the incentives to organize care, to organize the financing around the changes we want to do. I stop here. There's lots more to say.
Right. Okay. Well, thank you very much indeed. I've just got something from Chantal, so I'm going to interfere with Chantal's time now to ask this particular question that of Christian, which is apparently the President of the EU Commission announced in her State of the Union address on the 16th of September her intention to hold a global health summit in Italy next year. Do you have any insight into the agenda?
No, not yet.
Oh, okay, well, that's a straightforward answer.
Yeah. But anyway, just a short comment, because it is clear that we have to be also more active at the global stage.
Yes.
And one of the priorities that I discussed with Minister Spahn, which is now presiding the Council, the Health Minister of Germany, was to strengthen our role in WHO and also on the international stage. So it's clear that we have to take leadership in this direction, because until now we didn't, and it's a pity because we suffer because of this. So it's welcome to have this.
And Christian, I think just one other comment from what's coming in on the questions is, and I think something that you need to take back is thinking about what the European Parliament is doing to reinforce the importance of payments for virtual consultations, because again, it's all very well to have a reimbursement for physical consultations, but there has to be some balance to recognise that virtual consultations are going on. But look,
this is less the prerogative of European Parliament. It's more national prerogatives.
Okay,
national authorities. What I did it in Romania, putting a little bit of pressure on the National Health Insurance House, the body where I was president for almost 1 year, in order to speed a little bit and to reimburse virtual consultations.
All right.
Thank you very much. I have to go to migrate to the next meeting. It was an honor.
Wait. One second, Christian. You know the European Diabetes Forum can be your partner.
Yes. I think that's what we're here for. Now, look, Christian, I'm going to stop you because...
Yes, thank you so much. I will leave all the best, and I'm your partner. All the best.
But thank you so much, and actually thank you really a lot for and indeed for you all for finding time in your busy lives to help us. And now Chantal is going to wind up briefly so that we end on time. And I haven't left her quite enough time, but I know Chantal is perfectly capable of speaking rapidly and being brief.
Most of the time. So if I may have my slides again. And so this is, again, the moment when the right head will be above my name. I took pictures of all of you with my name under you, so it will be amazing. So I urge you all to go to the live flow of EASD, and you will see the amazing comments from the over 300 people who were in this room and who appreciate the topic of our discussions. I will again bring you back to our strategic forum where we said digitalization is important. I heard very clearly that there is indeed a readiness for digitalization. There needs to be willingness of partners And there I mean the medical professions, the nurses, the dietitians, everybody who needs to be engaged in healthcare, but not in the least of the person living with diabetes, and of course also from the payers. I think we heard some amazing examples from 3 countries where they are exploiting a little bit the COVID epidemic, the COVID crisis, but also initiated before already initiatives on digitalizations and doing medicine and diabetes care in particular in a novel way. I also heard very clearly, and again, Mr. Boussoy also alluded to it, that we need to be clever, join forces in Europe, join forces globally, but also exploit what is happening in other non-communicable diseases. And I heard that message also very clearly. There are hurdles to digitalization. I heard finances over and over again, of course. There needs to be a trust by the payers that they pay beyond the exchange of a handshake between a person living with diabetes and the medical team. There needs to be a trust that when we talk to patients on Zoom or on the phone, that we don't chit-chat about the weather, but that we really help the people live with their disease and improve their lives. And it was said by somebody, take the disease in hands. I heard also a hurdle on the GDPR, who owns the data. In my eyes, it's always the patient, but anyway. So yeah, that needs to be discussed too. And then again, I want to come back to the point of what Bastian said, that we need to go probably to a blended system where you have a hybrid system, where you have, on the one hand, digital contacts whenever you need it, and on the other hand, face-to-face contacts also when you or when the medical team needs it. And so that to me is such an important message. I also heard that it's Europe, but it's also the regions, it's also the countries. And so this translation, again, if you look here at my slide, of all of our efforts at the EUDF to the regional fora will be of the utmost importance. Here you see our 3-year goal is really to make a European blueprint messages that could be accepted not only at the European level but also at the national level. And then our ultimate goal, of course, is to optimize the use of technology, digital health and innovative treatments to support people living with diabetes, to give them a better life, not only a longer life, a life with less complications, but a better life. And so I end with this slide. I want to end by thanking all of the speakers. You were amazing. And you know, many people told me we cannot do this in so little time. We did it, and you gave your messages. They were crystal clear. I would like to thank the audience. I would like to thank all the member associations in the EUDF, our collaborative supporters of FPA. And I would really ask you to join us on our social media, on Twitter, on LinkedIn, and if you want to know more about us, go to the website or just send us an email here at info@eudf.org. So thank you so much. Thank you, David, for co-chairing with me, and I hope you have a wonderful virtual EASD conference. And honestly, I hope that next year we can also make it blended in a hybrid form, virtual and face-to-face. I miss you all. Bye-bye.